All right, I think we're ready to get started. You guys would take your seats. So we're really excited to host a Colorado native. Dr. Matlock grew up in Golden, went to Colorado School of Mines, and did medical school here at the University of Colorado, so a very rare breed. Thanks for joining us tonight. He's going to talk to us about shared decision making. So please put your hands together.
Thank you all for inviting me. You all hear me okay? Is that better? Okay. Yeah, so I'll give a talk called An Overview of Shared Decision Making Across the Translation Continuum. Conflicts of interest. I've received some grants from the American College of Cardiology Foundation, the NIH, PCORI, the American Federation for Aging Research, the Harvard Foundation, the Colorado Health Foundation. And I put this on here. I give a lot of talks to cardiologists. One of my anxieties talking to this group is a lot of the examples that I'll give are in cardiovascular disease. So hopefully the concepts will be applicable to some of the interventions and decisions you all deal with. But I talk to cardiologists a lot, and they allow me to be a member of the American College of Cardiology for about $100 a year, but I had to apply. And when I applied, I had to check a box of am I a geriatrician or a cardiovascular veterinarian? So I'm not sure what that says about the ACC and how they think about geriatricians, but I am in the division of geriatrics here. So an overview of this talk, I've broken it up into 4 sections, and I've kind of followed the translational T1 to T4 continuum to break down decision research in each of these settings. What is the basic science of bench research, and just a few examples. And then on to bedside research, practice research, and then some of the things that are going on in policy in this space. So I'll start with bench research. Start with this. And look at this quote. There's a 30% chance of rain tomorrow. And think about what this means. And now pretend like you were trying to explain what this meant to like a 10-year-old. I used to ask, I gave a talk on risk communication to the medical students for a few years, and I used to ask them to do this, and I would have people raise their hand, and I stopped doing that because it got so embarrassing when people were trying to explain what this meant. Well, Gerd Gigerenzer, a psychologist who does research in health communication and the psychology of healthcare decision-making, he ddid this study. He asked 750 people on the street, what does this mean? And he gave them these 3 options. It'll rain tomorrow in 30% of the region, it'll rain tomorrow for 30% of the time, or it will rain on 30% of the days like tomorrow. The most common answer was it will rain tomorrow for 30% of the time. The right answer is the last one. It will rain on 30% of the days like tomorrow. And they put some of the comments that people said in the paper too that were pretty interesting. 3 out of 10 meteorologists believe it will rain. 30% means if you look up at the sky and see 100 clouds and 30 of them are black. It's not about time. It indicates the amount of rain that will fall. Or I like this last one because I think it's also right. If we had 100 lives, it would rain in 30 of these tomorrow. But it highlights the challenge that we have as humans thinking about statistics and probability and what do those things mean. And so one of the things that a lot of people who've done research in decision making and some of the basic decision making is just the psychology of numeracy and the understanding of statistics. And here's a really stark example of what this can look like. So in 1995, the United Kingdom Committee on Safety and Medicines issued this warning that said, oral contraception pills increase the risk of potentially life-threatening blood clots by 100%. And this is from the New England Journal. You look the rate of abortions, and this is not a social comment on abortions, but I think we can all agree it's a proxy measure for unintended pregnancies. The rates of abortion in the years after that warning in the United Kingdom went up pretty precipitously. The actual increase was 1 in 7,000 to 2 in 7,000, which is indeed 100% increase. But that's a relative risk, 100% relative risk increase. It's an absolute risk of 0.014. The ironic thing, in 96, there were 13,000 additional abortions, 13,000 additional births, and the risk of blood clots associated with abortions and births is about 10 times the risk associated with oral contraception pills. So these numbers can be dangerous if used incorrectly. So what's wrong? In the psychology, they coined this term denominator neglect. Anytime we hear a percentage, and they've done studies in physicians too that we do the same thing. You hear a percentage, and you automatically put 100 as the denominator, or you ignore the denominator and assume that's out of 100 people. So you hear 100% reduction, people think that means everybody dies if they take these, or everybody has a blood clot. And this is a problem. And this relative risk, absolute risk thing is also a challenge. And there was a great article, one of Gerd Gigerenzer's mentees, this guy named Wolfgang Gaismeier. He did this study where he reviewed all of the abstracts over several years in the major journals like the New England Journal and JAMA and the Lancet. And he looked and he noticed that often the benefits are framed as relative risks and the harms are framed as absolute risks. And you see this, aspirin reduces the risk of stroke by 20%, but was associated with a 1% increase in intracerebral hemorrhage. And you can't actually, that doesn't mean anything. You can't actually compare those two statistics. And the journals, a lot of people have pushed the journals to use absolute risk. And you look at abstracts today, and at least in the major journals, and you're much more likely to see absolute risks presented in the journals. But it's because people don't understand the relative risks or they misinterpret them. Some of the work that I've done has been in implantable defibrillators. For those who don't know, an implantable defibrillator is kind of like a pacemaker, sits under the chest, has wires in the heart, and it senses for potentially lethal rhythms. If it finds one of those, it delivers a shock, just like an external defibrillator, but it's internal. Those were originally developed and used for people who passed out from sudden cardiac arrest and were revived by an AED or something, the person in the airport. That's how they were originally developed. This trial in 2006 or 2005 in the New England Journal was for primary prevention. They enrolled a large number of patients who just had heart failure and who were at risk for sudden death, but didn't actually have a previous arrhythmia. And they randomized them to placebo or the ICD. You could ignore the blue line. At the time they started the trial in the late 90s, there was a question of, are antiarrhythmics as good as the ICD? And you can see they're not. They're as good as placebo. And over 5 years, you can see a pretty large reduction. In the placebo, 36% of people died. And in the intervention with the defibrillator, 29% of people died. So Medicare looks at this trial and says, okay, we're worried about the cost of defibrillators for heart failure patients, given that there are so many people with heart failure, but this is really compelling data, and they covered defibrillators, which was something they were being pretty resistant to. So we surveyed everybody with a defibrillator at Kaiser, Colorado, about 400 people, and we got 300 people to respond, 295 to respond, and we asked them, if 100 people like you had a defibrillator, how many lives would be saved over the next 5 years? And these were people with defibrillators. And I just told you the right answer from 36 to 29 is actually 7. 7 out of 100 people would have their life saved by the defibrillator. But you see what people report. 20% or so said 28. About 30% said 53. 35% said 53 or more. Yes?
Did you give them that data to look at, or was that just based on their memory of the decision-making conversation?
Good question. That was just based on their memory of what they thought these are people with defibrillator, what did they think their chance of living with it was? So no, I didn't show them the data. Good question. We'll get into that on how you can communicate these things in a way that's better understood. That's a good teaser. And this is pretty consistent in the literature where people often overestimate the benefits of the therapies we provide. This has been shown over and over. And then it's also pretty consistent that people underestimate the risks. And that underestimation of the risks is a general rule that has a nuance. Once you get to really small risks or really rare risks, people tend to overestimate the risks. There was another good study where the University of Michigan has done a lot of work in how you communicate statistics in ways that people understand. And one of them did a study there where they gave people and told them their risk was 1 in a million. And then they gave the other half and told them their risk was 2 in a million. And then they surveyed them a few weeks later about what their risks were. And the people who heard that their risk was 2 in a million actually rated their risk as lower than the people who heard their risk was 1 out of a million. And the thought there is when you tell people 1 out of a million, people aren't thinking about the number 1 in a million. They're just hearing risk. And because 1 in a million is just kind of a term. Whereas you hear 2 in a million, then people are thinking, oh, 2 out of a million, that's actually not that very many people. And then they put it in their brain as a small risk. And then you ask them later when they don't remember what the risks were, but they think of those differently. So it can get complicated. I worry about that when you rattle off a long list of risks. that can also be harmful and difficult in the decision making. And this gets into another one of the psychologies. This is sort of a famous experience in psychology, but I'll show in the next example an example in medicine. But this is about the more options you give people doesn't actually help people make better decisions. Sharon Iyengar at Columbia did this study where she put jars of jams out at the grocery store. And on some days, she would put 24 jars of jam out with different flavors. And on other days, she'd put 6 jars of jam out. And on the days where there were 24 jars of jams, 60% of people stopped to look, but only about 3% of people actually bought one. And on the days where there were only 6 jams, fewer people stopped to look because it wasn't this beautiful rainbow of jam, but more people actually chose a jam and bought one. And people were more satisfied when the options were limited. Excuse me. So, and this one of those things, that more options makes decisions more difficult. So here's that sort of same concept applied to physicians. This was a survey of physicians, primary care physicians, and they gave them the scenario: you got a 67-year-old with arthritis. You've tried several NSAIDs, and you stopped them because they didn't work. So you decided to refer them to orthopedics to consider a hip replacement. And then half the people got the scenario on the left, and half got the scenario on the right. Before sending them, however, you check the drug formulary and find that there is one NSAID the patient hasn't tried, or there are 2 NSAIDs the patient hasn't tried. And then, so what do? If you had one NSAID, do you refer and start ibuprofen, or do you just refer and not start anything? When you have 2 NSAIDs you haven't tried, do you refer and start ibuprofen, refer and start piroxicam, or don't start anything? And when you give physicians more options, they're less likely to choose. So people on the right side, 3/4 of them, half of them would just refer and not start anything on the left. 3/4 would refer and not start anything once they had more options. And this is that basic psychology. Once you have more options, we tend to not want to choose. And this is partly what this field of behavioral economics, which is really just cognitive psychology, these are the kinds of experiments that they would do. If you're interested in these kinds of things, these are 2 great books. Dan Kahneman on the right won the Nobel Prize in 2002. He and Amos Tversky have done a lot of work showing that people don't really make decisions in this expected utility sort of way. And then last year, Richard Thaler, another psychologist, won the Nobel Prize in economics, and he wrote this book, Nudge. And if you only have time to read one book, I think the Thinking Fast and Slow is probably more classic, but Nudge is definitely a little more accessible and a little more interesting. The one, Thinking Fast and Slow, is like a textbook, but written for sort of a lay understanding. It's great, but it's pretty thick. And so this is another experiment that they did that is one of their more famous experiments. This is Kahneman and Tversky now. This was published in Science in '81. And this was another scenario of physicians where they said, imagine the U.S. is preparing for an outbreak of an unusual Asian disease, which is expected to kill 600 people. And then half the physicians got the scenarios at the top and half got the scenarios at the bottom. Said, you're the public health officer and you have to choose program A or program B. Program A, 200 people will be saved. Program B, there's a 1/3 probability that 600 people will be saved. So from an expected utility theory lens, those are identical. 200 and 1/3 of 600 are identical. The difference is one is conservative and one is risky. Then the people on the bottom got the same numbers, except instead of framing them as gains, you're saving people, they framed them as losses. People are dying. Program A, 400 people die. Program B, a 1/3 probability that nobody will die, a 2/3 probability 600 people will die. And these are the results. When you frame them as gains, 3/4 of people choose the conservative option. When you take the same thing and frame them as losses, 3/4 of people choose the risky option. And this is partly what they won the Nobel Prize for. This is prospect theory, showing that we don't really make decisions in an expected utility sort of way. We make decisions based on other things, like framing. And so this is partly what they've shown. When faced with gains, when you're saving people, we tend to be conservative. This is why we buy insurance. This is why the highest profit margin at Best Buy is that stupid little $15 insurance you can buy. You go buy a $100 Blu-ray player, and they're like, would you like to buy insurance for $15? You're basically saying you think that thing has a 15% chance of breaking in the next year. If you think that, then you probably should buy a different Blu-ray player. Or you should just insure it yourself. But because of this, you just gained something, and so now you're being conservative. So little insurance, which is buying conservative insurance is a conservative thing, you want to be risk averse. Whereas the bottom is more the gambling. You just lost money. This is the double or nothing. This is the Vegas. You just lost money, so now let's be risky. I just lost everything, so double or nothing. Let's double down. And this is deep in our psychology, and these are physicians. And the other fun thing about this is physicians don't like to see that we fall into these traps either. We like to think we're somehow better than these traps of psychology, but we're not. But this is some of the basic science of decision making. And there's you could do a whole talk on this, but I want to get to some of the other stuff. But there's a lot of interesting stuff that just gets into how our brains work when faced with decisions. So I want to move into sort of how do we take some of these things into the clinical space, and this is where we've done a lot of work. I lead the program for patient-centered decisions over at Accords. We do a lot of work in shared decision-making. We make tools to help patients make better decisions. This is not what shared decision-making is, but this is what a lot of people think it is oh, I have to give people options. This is respecting patient autonomy, and I would argue that this is pretty far from any sort of shared decision-making. My favorite definition of shared decision-making comes from a book in the 80s where they called it a meeting between experts. And I like that because it philosophically acknowledges the shared expertise. You have clinicians who are an expert in whatever the clinical scenario is, and patients who are an expert in them and what's important to them and their lives and their goals and their values. And I think bringing those together is sharing a decision. You go too far on one end, and you have the traditional model of paternalism where the clinician just tells the patient what to do. But you go too far on the other end, you have like that cartoon, and Timothy Quill wrote a great article calling this sort of consumerism patient abandonment, where you just say, oh, here are your options, you make the decision. That's not really sharing a decision with the patient either. One of the more common questions I get is, well, patients always ask me for a recommendation. Can I do that and be sharing a decision? And I think you absolutely can. Is your recommendation just based on evidence, or is it based on evidence and your discussion with them on what's important to them? If you're doing the latter, then I think you are just sharing a decision with the patient. So this is a busy slide. I don't want to get into this too much, except we do a lot of tool development, developing decision aids and tools to help people make decisions. And I wanted to kind of just point out those two big circles. When we develop tools, we often start with step one, the needs assessment. What are the important things in the decision? What does the evidence say? And then we draft something, and then we just iterate it. In other fields, this might be called user-centered design, but we take a version on a low-fidelity prototype, show it to some people, get their feedback, and then make a new version. We just keep doing that until we find something that is useful to both the patients and clinicians. And when we make these tools, we're shooting for three things. We want it to be accurate, we want it to be understandable, and we want it to be unbiased. And by far, that unbiased part is the most difficult. A lot of the tools we develop, like for the defibrillator or the left ventricular assist device, we get patients that tell us the tool we've made is biased towards the intervention. The clinicians tell us that it's biased against the intervention. But they both think it's acceptable, and then we think we're getting close. And we've never really found something that's pleased all audiences, because bias is a really hard thing to do. So these decision tools, do they work? There's a Cochrane review now. I need to update the bottom left corner to 2017, but this 2017 update had 115 trials of decision aids. And these decision aids improve knowledge, value, treatment concordance, satisfaction, doctor-patient communication, involvement. They lower conflict, they lower regret, and they lower the proportion of people undecided. And these almost always show evidence that they do these things in these highly controlled trials. Oops. Decision aids come in all kinds of versions. These are some screenshots from our defibrillator tool. In the defibrillator, there's this trade-off between sudden death and progressive heart failure. You might live longer, but you're taking away your chance to die suddenly, and people kind of want both options. So we present those as two paths. Yeah, you might live longer in one. And these kind of figures came from a JAMA article that we found in our iterative development. The patients understood these, and they were acceptable. We use some imagined future scenarios. You can't read them, but we try to use a quote at the bottom showing that both options are reasonable. I'm ready, like on the left, I'm ready to die. I'm not ready to die. I have so much I'm trying to stay alive for, even if it means getting shocked. I'm willing to do anything that can help me live longer. Versus on the other side, I've lived a good life. The idea of dying quickly sounds like a painless way to go. I've always said I hope to die in my sleep. going through surgery and getting shocked is not the kind of thing I want. So we're trying to frame both things as reasonable, framing both about what is your life like with the device. And then the data on the right is that same data I showed you in the slide previously, except it's presented as an icon array or a pictograph. And this gets to your question back there. This is, the University of Michigan does things where they even have a website called iconarray.org or .com where you can go and make your own icon arrays. But there's data that when you show people statistics this way, they're much more likely to answer a knowledge question correctly in the weeks to months following seeing the data this way, because it's very easy to understand, very easy to see what the benefit of that trial was, rather than saying 7%. And even if you don't make an icon array, they've also done research that people are much more likely to understand a natural frequency. So I try to do that in clinic. Instead of saying a percentage, I say, oh, about 5 out of 100 people who take a cholesterol medicine will get muscle aches, instead of saying 5%. Because people are more likely to understand 5 out of 100. Okay, that's not a huge risk. But these tools can come in all kinds of forms. We've made videos. These are pictures from our video tool. We've done competing patient narratives. Our left ventricular assist device tool, where we've kind of gotten into emotion. One of the challenges with this particular decision that came out of our needs assessment is people were scared. These are people dying in an ICU, being told that they should get one of the more aggressive surgeries being done in medicine these days. So we kind of embraced that emotion, said, you're in a tough spot. You have severe heart failure. Many patients like you have found this scary or confusing. Some patients have felt pressured to make a decision. So we just acknowledge those emotions, and there's some data, this is more theoretical than it is empirical, but there's some theory in the communication literature that if you just acknowledge the emotion, then people can more quickly get back to a cognitive space to actually make a decision. So we tried to do that in this tool. This is an example from, I've been working with Jennifer Stevens lastly and Andrew Kittleson on a tool where he is trying to help patients know what their rehab will be like after a knee replacement. And this is from a population of patients, what their knee flexion scores are in the time following surgery. And then what's really cool about what he's been doing is you put in some patient variables and you get numbers that are more like, you put in age, gender, and BMI, and you get numbers that are more like where that person's rehab potential should be. And then you can say, well, based on where you're at in your rehab, I thank Andy for giving me these slides, but I'm not sure what he would say when he presents this. Whoops. But you can kind of show where somebody is relative to other people making that decision. So we just started working on this and trying to think about ways of how do you present this to patients so they can see, oh, I'm not doing as well as others, or I'm doing better than others. I actually think this is pretty cool, trying to get these tailored presentation of numbers to patients rather than just going on a trial population. And it'll be interesting to see if that's more meaningful. And also I think there's another interesting thing about the Taylor statistics that's not really studied, but the social norming effect, where you say, oh, other people like you might be having more flexion, and if you were rehabbing a little harder, maybe you would get back to where you were. I'll have to see how that goes. It's been a fun thing to start thinking about. But these tools there's a lot of empiric questions in what should these tools look like? What is the best tool? And I think each decision might be a little different. In our team, we have some tensions. We do this quick, rapid, user-centered design, which kind of takes us away from what the decision theory might tell us to do. And that's been kind of an interesting thing in the literature. There's this tension between standardization and customization, especially when you get to the LDAD and emotion. You talk to the palliative care people, and they say, oh, that has to be a customized conversation based on a person's emotional state. Can you standardize pieces of that? And I think that's kind of an interesting question. And then as we've gotten some contracts from the American College of Cardiology to develop some tools, we've been in this sort of tension of being a slow, rigorous academic versus a fast product development contractor, and that's been sort of an interesting piece too. We want to make tools that people can use, and we want to be academic and rigorous. These are just tensions. It's kind of fun things to think about, but these things come up. So moving on to the T3, this is the problem. I mentioned that Cochrane review, 115 trials. And these are all beautiful little studies where the research assistant approaches the patient, they sit with them, and they make sure they watch the decision aid, and none of them are getting used in practice. This is the sort of bench to bookshelf phenomenon. This is why over the last 4 or 5 years in my career, I have migrated and have been doing a lot of work in implementation science with Russ Glasgow and the implementation science program. Most of the grants I've written in the past 4 years have been implementation type grants. Because implementation is really hard. So we make these tools, we go through this user-centered design, we make this beautiful tool, but then who's going to deliver this tool? Is it the provider? Is it a staff member? If it's a staff member, will they be empowered to use the tool on behalf of the provider? How will you deliver it? Will you give it electronically? Will you mail it in person? Will it be a print or a DVD? Can you get Epic to do anything? Will the Epic programmers help you at all? I don't know if you guys have luck with that, but we do not.
We have an intermediary in the house.
Oh, really? You guys are lucky. We've struggled. I don't mean to be offensive, but it's just the fact we have had no luck getting Epic to help us deliver these tools. And medical decisions are different. What's right for one decision, decisions about how aggressive should somebody be pushed to rehab after knee replacement, is really different than should you get an LVAD. It's really different than should you get a PSA test or take a cholesterol medicine. So I think different decisions require different tools. I don't think it's I'm quite confident it's not a one-size-fits-all approach for decision tools and decision making. And then this is actually the biggest problem, is when is that patient in their head making a decision? For the defibrillator, there's this referral pathway from primary care to cardiology and cardiology to electrophysiology. And we're trying, in our R01 right now, we're trying to implement the decision aids in that sort of window between the cardiologist and the electrophysiologist. But that's not perfect. We're finding, especially as we screen people here, somebody gets referred straight from the outside and ends up on the table, and we missed that patient and weren't able to deliver a decision tool. Or it's just really hard to know when somebody is actually making a decision and when you deliver these tools in practice. So there was a systematic review of implementation of these decision support tools, and you can see by the title, this kind of sums it up, many miles to go. And there were some problems identified. Clinicians tended to lack confidence in the content of the decision tools. There were lots of concerns about the decision tools disrupting the workflows. Lack of incentives were a major barrier. There was another survey recently of urologists about would they use tools, and they said we're much more likely to use tools if they're endorsed by our specialty society, which is partly why I've started working a lot more with the American College of Cardiology, because they have an interest in shared decision making, and if I can get them to kind of endorse the tools and put the tools out there, then maybe I have a chance of actually getting people in the real world to use the tools. But that obviously comes with a lot of baggage. We made a tool with them, and they immediately sent it to industry for feedback and came back with all kinds of comments of things they didn't like and how we framed things. They wanted us to say that this medicine was much better than this medicine. And they referenced some esoteric, poorly done research. But that's kind of what multi-stakeholder engagement is, I guess. So we've done a lot of stuff in cardiac procedures, a lot of stuff in advanced heart failure, done some work in colon cancer and hospice, and we're starting to move into other areas as I've worked like in the rehab space with Jennifer and Andrew, and worked with Amy Betts in the emergency room. She's done a decision tool for lethal means counseling for people who are suicidal and own guns but have been deemed safe to go home. They have lots of choices about what they can do with their guns. You can lock them, you can give them to a pawn shop, give them to a neighbor for 72 hours. And so she's actually kind of used these decision tool principles to help ER docs have that discussion, because some of her work showed that when patients thought, when the ER doc says, oh yeah, you should put your guns away, the gun owner basically thinks they're stupid, because you can't just give your guns away or put them away. There's all kinds of laws around that. That's kind of interesting, just ways people, or at least locally, have thought about applying some of these concepts. So moving into the policy space, this is, I think, really what gets me out of bed around this work. I kind of like this counterculture aspect of this, and can we get physicians to have better discussions? And I think that's where some of the exciting stuff has been happening these days. So let me get into the example of implantable defibrillators just a little bit. So this isn't my patient. This is just a free Google image that reminds me of a patient. But when I was a resident, it was about 2002 when defibrillators were just kind of starting, 2003 or so. And I was at one of the private hospitals. I did internal medicine here because when I was introduced, I haven't really left Colorado ever. And we were at one of the private hospitals, and on the internal medicine rotation at the private hospitals when I trained, you didn't really have much autonomy. We had a ton of autonomy at Denver Health, but we would admit patients and then stuff would happen to them and we had no control. And I admitted this guy from the San Luis Valley who was an old farmer and had heart failure, and he said, I don't want a lot of things done. I think he was about 77 or 78. He said, I just want to go back to my farm. Don't do a lot of things to me. It was okay. I wrote my note. We admitted him that night. And I go to see him the next morning and he's gone. And he's down in the lab and he's getting one of these defibrillators. And then I didn't know what they were really at the time. I'd heard of them, but this was before that trial I showed. These were pretty niche things in 2002, 2003. They weren't that common. And so I talked to him afterwards, and he had no idea what this thing did. He has this device in him that's now going to shock him when the night before he told me he didn't want anything done like that. And so here's that example again. And as far as medicine goes, this is a huge benefit. A 7% absolute risk reduction. This blows all of the cholesterol and blood pressure treatment that I do in clinic out of the water as far as the absolute risk reduction. So this is a big benefit. I don't mean to say this is not a great therapy. I have 3 small daughters. I'd get a defibrillator if I had heart failure. I wouldn't be happy about it. I'd be informed, but I wouldn't get one. But they come with lots of harms and trade-offs. There's obviously the procedural risks, but there's a lot of other interesting harms. There's some data that you have increased heart failure admissions. I talked about that trade-off of sudden death and progressive heart failure. And there's some data that people who get a defibrillator have more heart failure admissions. And the idea there is you took somebody who would have died of sudden death and kept them alive. So they've proven themselves to be a little bit sicker or have a little bit sicker heart. So they had more heart failure admissions. And this was one of the secondary analysis, one of the big trials. There's anxiety and depression and PTSD. I had a patient when I worked in the heart failure clinic for a little while who had a nightmare. He got shocked by his defibrillator. His life was saved. It was an appropriate shock. And then every night he woke up thinking he got shocked. He had a nightmare that he had just gotten shocked. And they would interrogate his defibrillator, and he hadn't been shocked. This was just the manifestation of his PTSD. And that lasted for about 6 months after the shock. And at the same time, he was very thankful to have the defibrillator and still be alive. And there's data on anxiety and depression with these defibrillators as well. Inappropriate shocks. This has gotten better as technology has advanced, but in the early days of defibrillators, they often had a hard time distinguishing an atrial rhythm from a ventricular rhythm. And so you could just be out exercising and get shocked. And there was a patient who was a pretty young, healthy guy who had a defibrillator for one of these congenital hypertrophic cardiomyopathies, and he was in Moab exercising. He got a little far and a little dehydrated, and every time he tried to get back on his bike to ride back, and his pulse would get to a certain rate, he'd get shocked. And he says he got shocked 10 or 12 times trying to get back to Moab. The newer devices are better, but this is still one of the most important things when I talk to clinicians about what should we convey to patients. This is one of the most important things that clinicians want to make sure patients understand, because it's really hard to explain that not every shock is an appropriate shock. And then there's device malfunctions, quality of life, and then potential suffering at the end of life is also pretty interesting. Like I said, I'd get a defibrillator, but there probably would come a time in my life where sudden death may not be the worst thing that could happen. Nate Goldstein did a survey of hospices in the country, and in the year prior to that survey, half of the hospices in the country had a patient get shocked by a defibrillator while they were at the hospice. And that's also, as defibrillators have gotten more common, that's become a little less because hospices are more aware of them. But, you know, it's an easy thing to forget where you send somebody to hospice for, say, metastatic cancer, and the hospice nurse sees, a pacemaker on the chart, or the family thinks this is a pacemaker because they don't know it's a defibrillator. And then the patient's dying and the family's standing vigilant and they start getting shocked. I mean, I'm not sure if medicine gets much worse than that, to be really honest. And those are, so the benefits and risks are some of the trade-offs. And then I alluded to this before of the type of death. This is, you know, defibrillators really only treat the sudden death. They don't really treat other types of death. And I get the most mileage when I talk to cardiologists out of this, because so much of the cardiovascular literature lumps mortality together as one endpoint. And that makes a lot of sense from a research perspective, but mortality comes in very different flavors and can look very different. You guys see that in rehab. I mean, it doesn't always happen this way. And it's interesting. You ask people, do you want to prevent sudden death? They say yes. You ask people, do you want to die in your sleep? They say yes. So now you have a little bit of a decision to make. And so this is a quote. We've talked to lots of people about this decision. And here's an example of one decliner who I think actually understood why he was declining a defibrillator. He was a former hospital chaplain, and this is his quote. He says, going into my decision is also the fact that I can't work because of my medical condition. I can't work at the hospital. I can't work at the church. My life is sitting here and watching TV. To take a defibrillator would just lengthen the process I don't really want lengthened. But this is the challenge. We also interviewed a bunch of clinicians, and we actually called this a theme in those interviews around defibrillators, where the clinicians said things like this: I think my biggest concern is if I convey the risks to them too strongly, that they will choose or make an unwise decision and not proceed with therapy. And I say that's beneficence because this was a good aha moment for me. This was early when I started doing research. It's these physicians, this was a salaried physician. He didn't get paid more for doing defibrillators. He just deeply believed this is what the patient should get, to the point where I don't want to tell them the risks. And this is a feeling I have when I protect my daughters from something bad on the news. Because I'm their father, and I'm supposed to be paternalistic when there's a bombing on TV that they don't need to see yet, because they wouldn't understand it. But this isn't how I necessarily want you talking to my father or my mother about their decisions or their defibrillators. I do think they have the right to know what's right, what the decision really is. But this came up in lots of interviews, and I felt this in clinic myself with patients of mine. We surveyed a bunch of physicians around this, and we asked them, to what extent do the following factors affect your recommendations regarding defibrillators for sudden death? And our goal was to find out how important patient preferences were. And in survey research, when you know there's social acceptability bias, like if you asked on a survey, are patient preferences important? Everybody knows the right answer to that question is yes. But if you hide something in a list of things and have people rate them, then maybe you'll get more of an understanding. And you can see mortality data and guidelines were rated very high. We scored this, it was a 5-point Likert scale. We scored them 0 to 4, 3.8 and 3.6 out of 4. Patient preferences were 2.9 out of 4. Patients' understanding of the ICDs were 2.2 out of 4. As far as how important those were to the physician. And I'd argue there is a right answer here. I think guidelines and data should be up there near 4 out of 4. And patients' preferences should be 4 out of 4. And maybe patients' understanding should be near 4. Sometimes it's hard to get understanding. Sometimes people can't quite get there. But at least their values and their preferences should be somewhere near 4 out of 4. And you bring those together, then that's that meeting of experts. Then you're really sharing a decision. And if we don't start getting better at this, this is where we're going. This was a great article in Health Affairs where they had focus groups of patients asking them, why don't you question your doctors? What are you worried about? And this is a quote from a patient. Is the guy going to be pissed at me for not doing what he wanted? Will he do what I want but resent it and therefore not be quite as good? Or in some way detrimental to my quality of care? And this is kind of what you see going on now, is this patient revolution. When I first saw this cover of the BMJ, I was excited. I'm like, oh, I do research in this space. There's a whole issue devoted to this. This is great. And then I went to the International Shared Decision-Making meeting, which was actually in Peru. The guy who hosted it is at Mayo, but he's Peruvian, so he hosted it in Lima, Peru. And he had one of his old mentors, who's an ICU physician in Peru, who does human rights work, give a talk. And he put this slide up, and he said, look at how awful this is. He says, this isn't what patients want. This isn't what doctors want. Nobody wants to be on the receiving end of a revolt. Every study says patients just want to trust their physicians. And then he says, look at this iconography. Think about how much suffering happened in the last century related to this iconography. And it just kind of struck me that is absolutely right. It's not about, patients don't want to revolt. And you hear this patient revolution, patient empowerment. And that's actually not what any study says patients want. They want to be involved in their decisions, but they really want a shared decision. They want to trust us. They want to work with us. And I think that's a better way to go as well. But I do think things are changing. This is from the 2017 ACC/AHA guidelines around ventricular arrhythmias and sudden death, just published last year. And in those guidelines, they said shared decision-making is a Class 1 guideline. And there's more and more guidelines coming out saying that shared decision-making is a Class 1 guideline. I warned you, most of the examples I have are in cardiovascular disease. But hopefully you can apply these to other areas. And then very recently, just started October 1st, Medicare mandated shared decision-making as a condition of payment for shared decision-making. And they said you had to use an evidence-based tool. And it was very flattering. They actually referenced our tool in that coverage decision as an example. And since then, we went from like getting 0 hits a day to getting like 400 hits a day on our website, which is pretty cool. We did nothing to influence that policy, but it was pretty fun that had happened. But Medicare has been doing this for more and more things. They've done it for lung cancer screening was the first decision where they mandated shared decision-making. And they did it again for left atrial appendage closure for atrial fibrillation. That's that Watchman procedure that you can use if you can't tolerate blood thinners. And now defibrillators. And we just got some insight that they might be doing it for the transcutaneous aortic valve replacement in an upcoming coverage decision. We heard that from one of the lobbyists at the American College of Cardiology. So CMS is on to this for whatever reason. Kind of creates an uncomfortable situation. Why would CMS be onto this if they're not just trying to save money and reduce utilization? So there's definitely pushback. But I think having a policymaker with this much power mandate these things does create an incentive to actually do some of these things. So I like the analogy of water for culture change a lot, where it just kind of works slowly over time and it creates these big changes. So with that, I'll kind of get to the end. And lots of people to thank. These are some pictures from our LVAD video of some of the people that were involved. And good, I've saved about 10 minutes for questions without keeping y'all late. So go from there. Thank y'all. Yeah.
For that, there are a lot of things that we do that don't have as much data, or there's so many patient variables that to present to them their likelihood of benefits is much muddier. For example, I'm part of the deep brain stimulation surgical program for Parkinson's and other movement disorders, and everyone's different. There's no test you can do beforehand, to see how it might go. There's some indicators. They're highly motivated, desperate people often, so they hear the benefits, more than they hear the risks.
Oh, right.
And and we perseverate over it, and we talk about, we team it, we have frank discussions with these patients, and even if you establish goals, so their particular individualized goals of treatment, there's the assessment of outcomes also changes because they have creeping expectations. So even if you establish clear goals and you have some metrics beforehand, preoperative metrics, sometimes their satisfaction is still poor, and part of it is that their expectations change. There's mission creep in their expectations of outcome as well. So, how would you apply something like this in a situation that's complex like that?
Yeah, well, I think that's a very good question. We were actually just talking about that this morning. I think shared decision-making sort of has 3 big domains where it kind of works. You don't need shared decision-making for every decision. That's one comment. Like, nobody wants a decision aid for should you take aspirin when you have crushing chest pain in the ER. And you're like, oh, here's your risks and benefits. Nobody really wants that. So it's not right for everything. But then where it might be right are decisions like the LVAD, big benefits, big risks. Decisions like mastectomy versus lumpectomy for early-stage breast cancer. Pretty equivocal outcomes with long-term follow-up. Or decisions, the third one that I think is the hard one, is decisions where we don't really have clear data. And that's what we were talking about this morning with percutaneous interventions for people with stable angina, that the data is really muddy, and how would you support the decisions there? It's interesting, I was just talking with Benzie Kluger. He and I were both at the PCORI meeting last week, and we had dinner one night, and we were talking about shared decision-making in deep brain stimulation. And I was asking, is that a good place for this kind of decision? And it is kind of funny because it's different. And I don't know, I guess the hypothesis would be if a patient better understood that, using some of these principles of communication and statistics, would they have more calibrated expectations and better, what's the word? Just a better understanding of what their benefits would be. That's what the research from the Cochrane Review shows, is people in the intervention arms of these kind of tools have more appropriate expectations of what their benefits would be. But then you get into this concept of satisfaction, which is really complicated. And regret is another one, where people tend to regret things as a function of their outcome. They may have had a really poor understanding, but they did well, so they have very low regret. Or they had a really good understanding, but they did poorly, so they have really high regret. And I do think that gets complicated. I don't have a great answer for you. I think I'd be hopeful that there is a way to develop some sort of tool that could help patients and clinicians have that conversation. I guess that would be the optimist in me. That maybe if through a nice design process you could develop something that would still support that conversation in a way where people would have more calibrated expectations. But I think it's easy in these one-off decisions like an LVAD or a defibrillator. It gets harder in some of these chronic decisions that you kind of play with over time. It's a good question. Other questions? Yeah?
On a related note, are there any data on the effect of a decision-making tool on the placebo effect?
The effect of the tool, is there less of a placebo effect when people are...
If you have the hard data in front of you, it's harder to think I'll be the one that this works on.
Oh, I see. So you show somebody... Yeah, the heart failure docs worry about that too. So we show people this accurate description of what an LVAD is, and then now maybe they're less happy and they have less benefit because we lowered their placebo effect. Right? No, I don't know the data. I don't know of any data on that, but I've kind of heard that hypothesis before. I think it's a good one. I think that gets into sort of the ethical debate of, well, should we not tell them the truth because we want them to get the placebo effect benefit? I think that's a tough argument.
Yeah, but you're gonna have
Other questions? Yeah.
Do you have data on using these kind of tools in different healthcare systems, like a capitated environment like Kaiser versus someplace like here where maybe it's more volume-based?
Oh, yeah. Absolutely. Actually, and some of it's in a lot of back surgery tools and hip and knee replacement. So Group Health, David Arterburn at Group Health did a large implementation study with some decision tools. And the highest uptake of those tools was in back surgery and knee replacement and hip replacement. And they actually saw a 30% reduction in the rates of those procedures. And then Dartmouth, Jim Weinstein, who led the sport trials, he also does a lot of work in shared decision making at Dartmouth, and he's a back surgeon and mandates everybody who comes to his clinic to go through the Dartmouth decision support group first. And they also saw a 30% reduction. And the Dartmouth Board of Directors were not happy with that, whereas Group Health was very happy with that, because Group Health is a capitated system. So I do think there's an incentive there. It's easier in those systems. For our LVAD tool, we just got a PCORI grant. We're going to try to implement it at all 170 LVAD programs in the country. And we're very concerned about, if this lowers utilization, will that be a big barrier to the uptake of the tool? In general, most of the time these tools do lower utilization, which is why Medicare is interested in them. There's only a couple of examples where it increased. One of them was prostate surgery in the UK, where they weren't doing very much prostate surgery, did this tool, and it went from 8% to 30% of men wanting the surgery. That was back in the 90s. But for the most part, rates kind of go down because we probably are using more than we should. But that's not the reason to do these things. The reason is to help the patient understand and get to the right rate. Does that kind of answer your question? I do think it'd be easier in a capitated system to implement these tools. But like I said, implementation hasn't really been successful anywhere yet. So, other questions? Yeah?
Two questions. One is about how long does it take to use one of these tools in a clinical encounter, and the other is how long it takes to make one that is roughly valid.
Oh, okay.
So you would like a
Oh, the icon array you can do pretty quickly. I mean, if you just want a little paper tool, you can make one of those in a couple, and you want to show it and do a little bit of iterative work, you can probably do that in a couple months. If you want to get to some of, we've done some videos and websites, and we've gotten those done at the fastest rate of about 8 or 9 months to a paper tool plus a video with some iterative work. And that's with a research assistant spending a lot of hours on it. We've been able to do that. How long do they take to use? I think a lot of that depends on the design. I think a big decision in the design of these is in-clinic versus self-administered. And we've designed, like the LVAD tool is a self-administered tool. And the implementation model is watch this video, we'll be back in a half hour to talk to you about it. And that's the way we've done a lot of tools, because we hear over and over that doctors don't want anything that takes more time. That's the way that group health project was, and that's the way Dartmouth does, is go watch a tool and then come talk to me. The Mayo group does this, they design tools for in the clinic, where they're these really parsimonious tools with just an icon array and a few natural frequencies of the risks. And they design in sort of an iterative way for in the clinic discussion for things like taking a diabetes medicine or cholesterol medicine. And on their research, it takes about 3 more minutes if the tool is really well designed for an in-clinical encounter. But it needs to be designed for that so that it meets the needs of both the physician and the patient. So that's a good question. Other questions? Well, thank you all for inviting me. I hope there were some pearls here.